Sometimes I like to just like sneak attack. But yeah,
Yeah.
I'm great. How are you, Dr. Quereshy? Nice to finally meet you.
It was pretty interesting how I just stumbled on your podcast with Ryan Diepenbrock, and I said, "Wow, this is pretty slick." And I went searching through and saw that you'd done a ton of these. So good for you. I'm curious on your journey.
Oh, well, thank you. Thank you. I'm very curious from your end as well. I mean, there's so much that I know, but also, for listeners, I'm happy to get into that from the start. But how did you know Dr. Diepenbrock?
So I finished my facial cosmetic fellowship in Salt Lake City in Utah, and years ago, 1990, I did my fellowship. So I'm a lot older than you. Then over the years, kind of developing my facial cosmetic practice and lecturing and so forth, I met Ryan. He was a rising star in our subspecialty area, and he approached me to help put on some courses. At the time, I was doing and still am helping to organize the cosmetic surgery lectures for AMIS, American Association of Oral Maxillofacial Surgeons, and I'm the chair for the special committee as well as the clinical interest group for AMIS. So I've been, Dr. Joe Nyamtu, you may have heard of Joe's name. Joe is kind of like our father in cosmetic surgery for all of us that are sort of the second generation. And now, Ryan and others are like third generation and hoping to continue to push that envelope of this specialty area. So Ryan came up to me after one meeting and said, I'd like to get involved. And of course, we love to have younger people involved and people who are interested, and of course those who have practiced the field. He also did his fellowship with my same directors, and that was in Salt Lake City in Utah. So Dr. Brent Kennedy, rest his soul, he trained both of us, just different time periods. It was, I think maybe a 8 to 10 year gap between the two of us. And then Ryan also had a career in academics, right? And as you probably heard through his podcast, and sort of like the same trajectory of where I've gone in my career as well. Kind of hit it off, and we serve on the same boards, the American Board of Facial Cosmetic Surgery. We served at the American Board of Cosmetic Surgery, involved with the American Academy of Cosmetic Surgery. So we had sort of the same parallel pathways of continuing education, giving back to the specialty, and so we have a lot in common, and that's how we know each other.
So
Yeah.
much in common. I'm glad we got to touch base on this too. I mean, it's so funny how, the world of obviously facial cosmetics, but then also oral surgery and dentistry, all these little worlds, they intersect in like a Venn diagram, and it just gets like kind of smaller and smaller, which is, I think it's pretty fun,
When I was looking in the career of we were all went to dental school, and I wasn't one of those folks, one of those people. And again, I was program director for 23 years, so I wasn't the one to give my answer. I wanted to be an oral surgeon before I got to dental school. I actually didn't even know about the specialty until I actually got into dental school and started interacting with some of the oral surgery residents. Wow. I went to Buffalo for my dental school. I'm a native of Toronto, Canada. And Buffalo is just obvious, close to home to Toronto. It's just a 2-hour drive along the Queen Elizabeth Way. The QE is that roadway. So it made sense to go to Buffalo. So anyways, but it was only until like my second year, after my second year, that I really got interested in actually the field. And not for the facial cosmetic part of it, just in terms of oral surgery and what a wonderful specialty it is to bridge, dentistry and medicine together. And I didn't want to have lost any of my dental knowledge. I have some friends who actually jumped the field. They went into oral surgery, got their MD, and then never practiced oral surgery. Went out to a different tangent, and I really wanted to make sure that I maintained my roots in my dentistry, and oral surgery is just that great hybrid bridge between specialties of dentistry and medicine.
Oh, it certainly is.
And then then getting exposed to the facial plastic part of it, I felt that my training was great for hard tissue reconstruction, orthognathic surgery, soft bony structures and relationships, and we just didn't have the soft tissue sort of experience to round it out. And I was really intrigued about the facial aesthetics and how I could intertwine that into the field of oral maxillofacial surgery. And lo and behold, I did a fellowship in facial cosmetics, and that was fortuitous because my practice now is probably about 35 to 40% cosmetic, and the rest is traditional bread and butter OMS.
So really?
Yeah, I didn't give up the oral surgery. No, I was program director for 23 years, and I just stepped off in July, at the end of July. So being a program director, doing facial cosmetics, but also all the other aspects of the field that I love. So TMJ reconstruction, treatment of benign tumors and cysts, resections, trauma, of course, and dental implants. So, still do a lot of that. And I feel very fortunate to have had the experience of 25 years of academics behind me, and now I'm fully in private practice now.
Yeah, yeah, yeah. Why this step back? There's so many can of worms I want to open because I want to go starting at Buffalo, the dental school, into residency, and then the cosmetics fellowship. But now that we're on that topic, why the step back? Why the step? You just only want to do private practice now? I mean, the director role.
It was a 25 years of great service to academics. There's inherent politics at every institution, and I think people can sort of read between the lines, and sometimes the politics can outweigh and has its, if you will, just the timeline of when to step back. You sort of have to know when that is. And I
Yeah,
feel that after 25 years, that's a quarter century. And I think that not that it was a rite of passage, that I wanted to give back to the specialty. And I felt that doing 25 years of service in that realm, and certainly I'll still be involved in education and various different avenues, using AAOMS, as a platform, other organizations such as the American Academy of Cosmetic Surgery. So I'll always be motivated to teach and motivated to share knowledge. That's been my passion from the beginning. But I think 25 years is a good run. It's a good number, good round number.
it certainly
And
is.
being able to have the privilege to influence a lot of those residents that have come through, that I certainly was very much involved in picking them, training
Yeah.
them from grassroots, from ground zero, to people who have been out in practice now for 25 years. And I've been very fortunate to be in that position. But it was time to move on, kind of like, switch gears a little bit for my own career. I'm not a spring chicken anymore. And but it was a good run.
I still a spring chicken. Come on, come on. And also for listeners, you were at Case, right? Case Western.
That's correct. Yeah. So right from my residency, I mean, that's where I trained. And I was fortunate to have matched at Case Western, and Cleveland, Ohio. I'd never even heard of the program until I started interviewing around, right? And it was actually one of the only 5-year programs back then, and this is 1993. And of the number of 5-year dual degree tracks, Case Western was one of them. Harvard, Mass General, if you went to Harvard Dental, it was 5 years, and UConn. So those are the other ones. If you were looking for the dual degree track, or traditional 6 years. And I always wanted to, if I was going to do this, my intent was to do it with get as much education as possible. If I was all in for it. And then not knowing what fellowship I wanted to do, if I even wanted to do a fellowship, I felt that would give me the best footing, is to do a dual degree track that could open the doors for any opportunities that, may come my way, and which it did. And then, and after I came back from my fellowship, I was recruited to come back on faculty before I even left. I just had the inherent, nature of teaching and doing research, and I really loved that. And I felt that, I had to convince my wife, of course, and
Of course.
convince my 2 young kids at the time, who are now, 30 and 28 years old, 29 years old now. But they were small enough that they didn't need any convincing. But certainly the boss needed to be convinced that I was going to choose a career in academics, and successfully was able to do that for 25 years. Our program was very unique in that it allowed me the opportunity to actually have a private practice also at the same time as having a full-time academic practice, and that was quite unique. And the foresight of one of my former mentors, who was the chairman of my department and the former dean of the dental school, Dr. Jerry Goldberg, who had that insight to be able to create a program and academic program where faculty, not just myself, but others in different disciplines, could have an outside extramural practice, and then also be able to successfully have an academic practice and teach. That was, unfortunately, academic practices, as the saying goes, that sometimes they don't pay very well. The economics of that is such that, you do have to be able to attract good people in academics. You got to show them money and show them the ability that they can make a living, and be successful at doing both. And knock on wood, I was very successful doing both.
Oh yeah, you certainly were. And I mean, you did it all. You did it for 25 years. You've been practicing also. So now you're full time in that practice that you were developing over the time, parallel to being the director of the program, right?
Correct. And that for lack of a better word, my practice name is the Visage Surgical Institute, and
I saw that.
we
Yeah.
train dentists. We have obviously my referring colleagues. We do study clubs like most private practice OMSs do, and I was doing that in parallel, and it was I'll say it was taxing. Along the way, I grabbed my MBA as well. I did that part time after hours, and I just graduated in 2024. Taking night school for 3 years, every Monday night for 4 hours to balance that with the academics, and so there've
And the
been some challenges
kids
along the way, and
and
the
the
kids.
wife.
Yeah,
Yeah.
yeah.
That's a lot.
So, but it's been great. It's been great to do all that. And now, having the MBA has allowed me to kind of see the errors that I made early on in my own practice. And granted, it wasn't a full-time practice. It was a part-time practice, but we ran it at a scale, a full-time level scale, with only 2 days a week, presence in the community, but producing like a full-time practice.
Yeah, yeah. I just wanted to show your website really quickly. I'm just pulling that up right here, right?
Yeah, there it is.
I
Yeah.
just saw your About Us. Well, I just wanted to give viewers, so they could see your. There you go. There we go. So they could
Yeah.
see your beautiful website right here, and if they're
Thank you.
interested in your services and stuff. So, but
Yeah, appreciate that. Appreciate that. And
yeah,
I've been fortunate to be, have like any successful business. It's all about the partnerships that you develop along the way, both in industry, right, and on the business sector that can allow you to be productive and be efficient. And now having the MBA, it's about economies of scale and how can I go beyond that? And that's really what I'm looking forward to in the next sort of phase of my career. As we say, we're probably in the third quarter of life, right? And hopefully, yeah, I mean, I think that's what I'm looking forward to. And again, it brings on a set of new challenges and hopefully some fun times.
oh yeah. There's a lot of fun chapters. There's always another fun chapter to explore, right? I just wanted to touch on before, because now I'm going to go back a couple of minutes here. I know, but I just kind of want to give viewers kind of a sense here. So you had mentioned three programs that were dual degree. At the time, you said Harvard, UConn, and Case Western, right? When you said dual degree, you mean the 5-year dual degree at that
That's
time?
correct. So at that time, there were only 3 programs that offered the MD degree in your training in a 5-year curriculum. I will tell you, and I'm going to boast about it because I maintained that 5-year curriculum at Case Western, while all the other programs have pretty much phased out to 6 years. Now,
They have all of them.
I think Mass General though, and I have to check with the chairman, program director. I believe if you're from the Harvard Dental School as a dental student, and you match at Mass General, I think it's still 5 years, but I could be wrong. That could be the only other program, but again, you'd have to have that direct connection from Harvard Dental School. But as far as I know, we're the longest running 5-year short curriculum, and that's really because of the exemplary effort by my residents who've done really well in medical school to maintain that relationship. It's really with the School of Medicine to allow the medical school to allow us to, I wouldn't say the word abbreviate, but we don't have to do all the courses that some of the 6-year track programs have to do in their second year of medical school. And so that's a relationship that we've maintained over my tenure of 23 years of being a program director. So it's, kudos to the residents who came through this program and have graduated along now, and kudos for us to maintain that relationship on a personal level.
For sure, for sure. I don't think all those years are necessary, and all those rotations, all those classes are necessary. I mean, how many rectal exams do you really need to do as an oral surgery resident? You know what I mean?
So,
Sure.
and this is going to dovetail into where is the specialty going in terms of curriculum development. And we've seen in the last couple of years, and there is a little bit of an upward trend of applicants, students interested in this specialty not feeling the value of a double degree. And what's happening is that there are more and more double degree programs not matching in their full capacity over the last 2 years. So I was fortunate enough to be on the Committee on Education and Training for the AAOMS, and we are a committee made of program directors, and I just came off of chair of that committee. And just this last year, we had this, again, 2 years in a row trend of students not wanting to do the MD degree training. What that ended up happening is that there were a number, 23 spots open in those dual degree programs. Not the single degree programs. They were the dual degree that had unmatched. My own program at Case Western had 2 out of the 3 unmatched. So we're scratching our heads. What is happening? What is happening to the specialty, and what is happening to the consumer because our students and entering students are the consumer of the programs, right? They're the ones that are vying. So think of it like a business. So we got to look at, again, the economics of any business when you see a downward trend of the economics of the programs. And so we're the assumptions are that incoming students have a lot of debt. There's college debt, there's dental school debt, and now you're tacking on an extra 2 or 3 years of medical school debt. And the perceived value of the MD degree is not what it used to be. If you look at the dynamics and the history of the specialty and what the specialty wanted to do 30 years ago, may not be what the product of the specialty wants to do now, which is basically office-based surgery, dental implants, dental extractions, and not be involved in hospital, not be involved with trauma care, not do bigger operations. And so we're seeing definitely a mindset shift of what candidates want to do. Now, the dual degree programs, you will have applicants, have their routine spiel at the interview. Why do you feel the MD degree is important to you? Everyone can say, I'd like to have a career in academics and a career in private practice. I'd like to have a balance. The fact of the matter is that doesn't exist. Either you're all in or not, at least early on. And we all know.
You did it.
Yes, and there are not that many that can do it. And it's also because the program allowed me to do it.
Yeah.
So you have to have a match. You have to have the perfect balance, and not all institutions buy into that, and they buy into all or none. You want to be academic, then you got to be 100% on the campus, in the hospital, in the clinics, and you don't have any time to boost up an extramural private practice. So these are the dynamics of what's happening, and really, the value of the MD degree has got to be what we have to go and preach to the dental student, to the pre-dental student, why an MD degree is valuable, or what can you do with that MD degree. Maybe not knowing what they can do with it, they don't understand that it's important or not important. But we're definitely seeing a trend where it's not as important as it used to be. They don't feel that there's a value. If you have 2 oral surgeons in a community, one's a dual degree, one is not a dual degree, I can't say for sure that the one with a dual degree or the one with a single degree is a better oral surgeon. I won't say that. Right. They're equally trained, but one might have an added skill set if they went and did a fellowship. I can say that the one who has the added skill set might have a little bit more training and might be more skilled in that certain area of specialty. So for me personally, doing a facial cosmetic fellowship, I think that validated my reason to do the dual degree track.
And now it's 34 to 40% of your private practice. So it makes sense, and you incorporate that. You do it every day. So it definitely makes sense. And then you bring out that passion and that interest, and you expand on that skill. So it totally does make sense. I get asked this question all the time. Why the 6-year versus the 4-year? What does the 6-year have? Well, it has the MD. What do you get with that MD? And it does. But this is a really big can of worms. No, this is really good to open, because Case Western.
It's a big issue because let's just say that if half our programs are dual degree programs and they're not matching, so what ends up happening? So now you're in this post-match scramble, and we all know if you've been involved in academics or even have colleagues, it's very stressful for both parties, right? And it's not just, I have a list of people, I can just pluck them and they'll come here. No, it's not as simple as that. You've got 23 other places that are scrambling for the same pool.
Yep.
And the pool is shrunk. So now you've got people, first of all, I would say less people want to do the dual degree, and they're in this post-scramble match. We're all competing, the ones that are open spots, competing for the same one guy or one gal.
Yeah.
And so we're in a predicament that, it's actually, it's a buyer's market. We're not the seller anymore. It's a buyer market. The student can go where they want to go now, which is a good thing for the student, but it makes it tough for the programs.
It does. I'm very curious to see where it goes this year, because it was 2 years ago, 21 of 22 unmatched spots were 6-year, and then last year was 23 or 24.
Actually, it was higher 2 years ago. It went down a little bit this year.
So, sorry, the 26.
2 years ago was 26, correct, and now it went to 23. So we had a little bit of a drop, but still in the same bracket of worrisome, put it that way. And the leadership of AMIS is doing a great job in looking at this, and I was fortunate enough to be on a task force and be part of at least some grassroots efforts where we're going to have to sort of kind of anything like anything else. You got to market. You got to market to the consumer what the value is, and if that perceived value makes sense to the person, then you got to win-win.
I am very concerned about this. I do, because I give this stuff a lot of thought, and I talk to a lot of people about it. One is marketing. We have to act. We have to show and act on that value forward. And what do I mean by that? Like, yes, I think having the MD is tangible and very much value as far as applying to the fellowship spots. I think that is very good. I think we need to add more benefits to the 6-year degree. And you know what? A lot of we can't take that away from the interest of dental students to want to do implants and extractions and wisdom teeth and sedations in a clinic setting. I think we have to incorporate all of that and show it on the marketing, like you said. But very importantly is I'm seeing a trend in dental schools. They're pushing and pulling, the hospitals are pulling the oral surgery residents away from the dental school. And who's filling that spot? The periodontists. And I have nothing against periodontists,
Sure,
right?
right,
But
right.
periodontists are filling that gap. And guess who's managing more complications at the dental school now? Who's doing sedations at the dental school now, right? The light,
Yeah.
moderate sedation, sure. But they're stepping into the zone that oral surgery is creating a void of. And I think there's a big issue here. Because who do they call when when a patient faints? And they're not calling the periodontist department, they're calling the oral surgery department in the dental school. So there's a lot of that going on. And my last point on that really quickly, the periodontics departments are increasing their sizes. They're increasing their students year after year. Sure, the periodontics residents pay for it. I get that. But the foothold, we need to keep that foothold in the dental schools. We absolutely do. I have dental students coming up to me throughout residency. The NYU dental student, I went to Stony Brook Dental School, but the NYU dental students coming up to me and saying, you guys place implant? Yeah. The oral surgeons place implants. Some of them have no idea, and they're literally 4 years. D4 is graduating dental school. So I've been taking a lot of input across the years from different people, different dental students, different professors, everything, attendings. I would love to be a part of those conversations because we need to build in this profession. In the last 2 years, these numbers are starting to get a bit concerning.
Yeah, and so how is that going to affect, the people in private practice? Unfortunately, it's going to be a trickle down, like you just mentioned, that the dental student, the graduating dental student who has not had experience with relating to oral surgery, is not going to be thinking about oral surgery for their implant
Exactly.
needs. They're going to say, well, I had a great relationship with the perio guys at, NYU or wherever that might be, or Case Western. I'm just going to call my local periodontist. And they don't even give the oral surgery guy a chance. But when the reality is, in private practice, oral surgeons are in the community and are reliant on these referral patterns. And I have been preaching to my residents, and we have an AAGD program at Case Western, and I've been preaching to them that you have to be available. The A's, right? The A's of success: availability, ability, obviously, affability, and accessibility. If you don't have any of those A's, you're not going to be successful in your practice. And you have to, again, look at that referral base and treat them as colleagues, not that, because in dental school, for some reason, the oral surgery residents, chip on their shoulder. They got accepted to a dual degree program. All of a sudden, their egos have become like, you have this big disparity amongst the egos between the dental students and the resident. And that's what they remember, unfortunately. These dental students are going to remember those bad experiences and say, I don't want to work with the oral surgery resident. And that comes from within each program doing its effort to maintain a relationship and build a relationship with the dental student and not have perio cut in and cut in on our turf, unfortunately, because we have spent a lot of time in hospital. We think that, big surgeries are, and the reality is the graduate oral surgery resident, the new graduate, doesn't go to the hospital. That's the reality. They've been trained in all the larger procedures. Unless you're a true academic practice, your first couple of years in private practice, some of my residents are joining DSOs and dental DSOs, large corporations, Aspens of the world, of the country, and they haven't set foot in a hospital and taken a trauma call. Why? Because they've got bills to pay. They're newly married. They've got loans to pay from dental school and medical school, and they're trying to just to survive.
And the hospital's not paying them. The hospital's
No.
not paying those loans back, right?
Right.
That's also a tough situation. And just also on that, you were just saying the politics. Sometimes the politics of the bureaucracy of the hospital, it's a big headache to deal with. As you know, you've been doing it for 25 years, and now you're in full private practice. It's a big undertaking, and you're not getting the ROI. You could deal with the bureaucracy all day long and finally win. And then you could just start to get those cases into the OR a little bit more. Get your cases, make sure the instruments are sterilized. You're not losing things in between. I mean, I could go on with it.
Oh, of course we could. And, especially if you go to a hospital that doesn't have a OMS service or presence, you're going to deal with staffing and nurses that have no idea what you're doing. There's post-op recovery care in the PACU and the floors. You have to put effort if you want to establish yourself in a hospital. And frankly, I mean, the new graduate just wants to get out, and having to deal with the bureaucracy of hospital practice or even have a presence, but if you don't have instruments, you're used to doing orthodontic surgery with certain type of instrument. They don't even have trays for that. You've got to deal with that. You've got to deal with the vendors. And then there's the other piece of it is the insurance reimbursement
Oh,
for hospital-based surgeries for the hospital. Next thing you know, you're doing custom, you're so used to doing custom plates and screws with KLS and Stryker. They see the bill, they're like, what is this bill? This is a huge expense on our end that we never knew that existed. And all of a sudden you're now, so low on the pole that they'd rather just say, you know what, we don't need you here at our institution. And that's very frustrating. So we've got this vicious cycle that we're so many challenges. Our specialty, it's unbelievable how, as we have dissected a little bit of this onion, that we've got this community-based problem and we got a hospital-based problem, and we don't know where to fit in.
it's a big problem. And you know what? You know who's losing? One is the oral surgeons, right? But number two are the patients, because there are things in our profession that only we can provide. I mean, the orthodontic surgery is life-changing. Everyone knows this. We can't even provide it because that bureaucracy is getting in the way. The insurance reimbursement is getting in the way. Oral surgeons are losing money to do this procedure that we want to do. We want to change someone's face. We want them to be able to phonate correctly again. We want them to be able to eat and function and go to their job interview and just feel confident again. And a lot of surgeons can't do it. One, yes, the loans are tacking up, working in the hospital settings now, but we're losing money because we have to take a full day off the office. We still have to pay our staff. And then we have to go to the hospital and do all these things, and we have to fight against the politics. We have to take call on the weekends for months and months just to get that hospital privileges. These are a lot of and I appreciate that we are able to have this conversation because people can listen on this.
These are the realities of real life oral surgery. And I think, students don't even know this, but again, not to deter them away from choosing the specialty. I'll be the first to tell you, bar none, there's no other career choice. I have, one child went to dentistry. She's doing dental anesthesiology. She was headed towards oral surgery. I have one that's going to ENT who wished he went to oral surgery. My youngest is starting dental school next year, so hopefully he'll be on the oral surgery track. But I toot the horn of the specialty because it is, bar none, the best specialty. The challenges of doing, orthodontic surgery for nominal reimbursement, especially if you decide to be on medical insurance plan, you're not going to be reimbursed for the effort that it takes to put those cases together, for the hand-holding of those patients and the orthodontic referrals, and then taking them to the hospital where, you have to be, there's no resident with you, you're doing all your orders, you're rounding yourself, so, there are those challenges, and then it becomes like, it's not even worth it when you talk about the remuneration compensation for an orthodontic case. So that's really what we're fighting up against is if we got paid for it and it would make it worth our while. And then I'm not saying that we should be driven by the compensation, but it helps to be rewarded for your good efforts.
That's a great way to put it, right? We're not driven by the compensation, but there needs to be a certain amount of support, just plain out support for providers. I mean, there was a chief that graduated before me. He had over $750,000. He had $750,000 of loans. He's not paying that back before 50. He's 35. He's graduating with a 6-year degree, just starting out. He's not paying that off before 50. What about by 60? I don't know. Getting a house. He finally got a car. Now he's got to drive an hour to work every day, right? Working for the DSO. He's not hospitalist. He's not board certified. He's not taking that exam. And so I want to bring this up, and I appreciate how involved you are because I can pick your brain. You were saying how, you guys are hitting the drawing board, the chalkboard on how can we bring up this profession. I love that because I've been mentoring on these social media platforms for years. I only want to expand this profession. We got to make sure, because we're not going to tell false things to the pre-dental students, to the dental students. We got to show them what we're doing and the direction that oral surgery is going in. And I think this is where
you think back to your own, look at your own, your own personal experience with the specialty, right? There was that one experience, and who knows what your dental student you were, maybe you weren't, maybe you were, it was pre-dental, but there is that one experience that kind of like really hits you in the heart and you hold on to that experience, and that's why you chose this field. Of course, with every field, there's stuff that we're not going to like. There's every field that we're not going to be that's going to be the negative for us. But by and large, you chose to enter this field because of that one experience, because the impact either it made on that patient or on you. And that's where we have to, like anything else, it's like value proposition.
Yeah.
And these
Yeah.
are MBA terms, but you have to derive the value of the specialty, and it's going to be different for every individual that actually takes that leap of faith and applies and goes through the entire process of applying and gets immersed in the field. Obviously, there are challenges of academics and being at the top of your class and so forth. But put that aside, that's what we have to do. We have to drive that value for each person.
Yeah, and I think we have to bring the value first. Some of the ideas that I think we need to, I don't know about mandate, but make requirements. I think we should have oral surgery programs, minimum of 5 arches of all annexes. I think that should be a requirement. That is going to immediately expand the dental student interest in it. They all want to do implants. Everyone wants to do implants. It's a great case. It changes people's lives. It's similar to the dental alveolar aspect, in a dental alveolar aspect to orthodontic surgery, right?
So let me ask you a question.
Please, yeah.
When you were a resident, did your program ever go through accreditation while you
Yes.
were a resident? Okay.
Yes.
So I sat on that side of the fence as well, right? So I was an examiner, going to the programs and visiting, and I also sat on CODA. So for oral surgery, there's 4 of us. We look at all the reviews of all the programs that come in every year, and the ones that get dinged, or the ones that need attention, etc. If you look at the standards of education, that's called the CODA standards, and you've heard of that term all the time. Our CODA standards for compliance for an oral surgery program is very minimal. In fact, an oral surgery program in Timbuktu could open up, and you only need like 80 cases, 20 in each major category to consider yourself as an oral surgery program. Where does it say if full arch is one of them? Or, it's a broad ranges. So under the reconstructive category, you could consider full arch as a reconstructive category, possibly.
Of course.
But the accreditation criteria, if you want to change those to make it more appealing to dental students, that hey, that's part of being an oral surgeon, then you have to go look at the standards. You have to look at the standards that the programs are made. Like orthodontic surgery, you only need 20 cases for a program to be in existence in your chief year to do 20 orthodontic surgical cases.
That's right.
It's not a lot. I mean, it can be done. Some programs are very strong, but there are some programs that they're weaker in these areas that don't have the numbers just because of the actual demographic of its location. But yeah, if you want to change to have full arch in there, specifically full arch dental implants,
just 5 arches. I think, but here's the thing. Here's my point. If we don't do it, is one of the other professions going to try and do that? I could totally see periodontics trying to do that. And they're setting up their departments to pretty much do that within the next 5 to 10 years. Oral surgery needs to be the one to do that. I really think we need to do this. It's going to expand the job market for oral surgeons is going to immediately explode, right? Because we have these all on X implant centers. They're looking for people that are experienced in this. If every oral surgeon is almost every oral surgeon resident is graduating with these, right? And it's just 5 arches, but they have some experience. They could figure it out if they've done the trauma, they've done the orthodontic surgery. 2, it's going to expand that interest as a dental student, right? And now we're putting the value proposition, it's right there. We're mandating it for students. They're going to love that. And now we could go through all the. You see what I'm saying? Now I know it's very hard to do because you can't guarantee patients coverage for these procedures. But how are we getting them coverage on orthodontic surgery in a similar sense? You know what I mean? We're fighting with those insurance companies to show them that this is an absolutely medical necessary. The skeletal deformities, dentofacial. I think we could come along a sense. This is where we need to go with the specialty. I've been thinking about this for years.
Yeah, no, great point. And I think, at least in our program at Case Western, my job was to increase that number of full arches, and we basically, price cutting, right? Competing with the clear choices of the city, and trying to get the residents experience, and really not looking for, again, monetary gain for the department. We were giving away the arches. I mean, we did. From the surgical side, just $8,500, for extractions, bone grafts, implants, that includes the cost. Of course, we have the relationship with the implant vendors, and then we would, negotiate with our AAGD or PROS department to restore the cases with us. And, and if you wanted to go into guided technology, and that's a whole different, set of costs and increased costs if you're going completely guided with stackable guides and then doing now the, micron mappers with, photogrammetry and those things, of course, that's going to raise the cost. So
Yeah.
I think if you're just trying to look for experience, basically just slash the costs. And these aren't, the residency should not be in the money making business of it. They should be more in the experience making business.
Absolutely. Yeah. And I mean, what happened with orthodontic surgery? They're getting reimbursed. Some of them, it's like 500-600 a jaw. Some of these,
Yes.
especially in New York.
I did
So
in
it's,
Cleveland for years. I mean, that's why I took on all those cases, but I had the residency support. I didn't have to do all the workups. I taught by going onto the virtual meetings and planning with them. You can only do that if you have that kind of support system, and I didn't really care. Now, in my private practice, I'm not going to be doing it for $500, a jaw.
you
You know,
can't.
can't do it. I mean, like you said, you mentioned it already. You step away from your office, you're paying staff, you're not even there. That's just not even going to cover it. And the headaches of the pre and post-op care for these patients.
Oh, 100%. And now my proposition with the All-in-X, it's just 5. I'm just saying let's mandate 5. And I'm not saying let's take away from orthognathics, no. But what the All-in-X is, it's going to expand our relationship with the prosthodontics department and the advanced general dental restorative dentist department. That's what we need in the dental school. The orthodontics department, we work with them with orthognathics all the time. This is how we expand and gain those connections and relationships with the other departments. And I think it really brings it back to home. My last proposition would be getting a little more time with residents in the dental schools. I think that would be huge for it. Let them teach a little bit. Could you imagine a resident, they're going to complain and everything, but rather than taking call, I think they wouldn't mind giving a quick presentation at 9 a.m. on a Thursday morning rather than be running around, as
Yeah,
long as
we,
it
we,
doesn't
we, we
go all
we
the
do
time.
that a little bit at Case Western.
Yeah.
I teach a course in the third year. It's called Advanced Oral and Maxillofacial Surgery. So it's not like extraction, but it's more like TMJ surgery. It talks about benign pathology surgery. There's dental implants. And I do have some of my residents, but to them, look, you weren't a resident too long ago, it becomes a chore. Like anything else. Oh, I got to teach the dental students this class. Dr. Quereshy made me do this. And you, as an educator, I think, though, this is good for you, right? This is broccoli for you during your residency. So you kind of give back. But those are skills that you need. They need to actually develop those skills because when they're finished, they're going to go out into their communities and lecture.
Yes.
And they need to have those. They need to have that skill set to be able to be the educator in the community. That's what we've always been. But we've been the people that the dentists look up to. And when there's a medical question or a complex pathology question, we want to be the ones that they call, not the periodontist.
Exactly. And I'm
Yeah.
seeing so many of these dental schools. Stony Brook. I went to Stony Brook Dental School. The oral surgery program was there when I went there, but they're not there anymore because
Yeah.
the LIJ, the Northwell, it pulled them from the
Pulled.
dental school. I'm concerned that this is more of a trend in some dental schools, not just one, but multiple dental schools in the U.S. I know at NYU we get pulled. We only have 2 chairs for 1 or 2 residents to be in the clinic at the dental school at NYU. NYU is a 400-person class. We should be getting more dental students over there. And so it's just my ideas for this stuff. But I'm glad we were able to touch on that. I wanted to get back to your kind of pathway too, from
Sure.
Buffalo to
Yeah.
Case to. But no, we're definitely Dr. Quereshy. We're going to have to revisit that another time. But I wanted to hit a couple topics too,
Absolutely.
because
Absolutely.
you
I
were
think
such a
some of
plethora
these
of knowledge.
topics are, like I said earlier, I love this specialty. You want it to flourish. I want it to be there for many years beyond my own existence, right? And that we're at the cutting edge. I think sometimes that if you look at the way the specialty has evolved, we've got into plastics, we got into head and neck oncology and cleft and craniofacial, and those are all within the realm and scope of oral maxillofacial surgery. What ends up happening is that you leave the door cracked open just a little bit, and then you've got another group coming in behind you that is looking to pick up the crumbs that you left behind. And that's what we've got to be very careful about going forward. And sometimes, it have to be mindful of all that. And it's important to expand. I mean, we want to expand, but without losing. You got to expand without losing,
Yeah.
and we just got to be careful of that.
Absolutely, absolutely. That's why I like to we're planting seeds on how we can grow as a specialty and ultimately make it better for the future. All around expanding without detracting from any one area, because we still want to place residents towards plastics and cosmetics and head and neck cancer. So all the it's an all the above, and it's not easy, but it takes some really bright minds like yourself and everyone else that I have so much to learn from. No, to come together and let's figure it out. Because
Yeah.
I've been talking with dental students and pre-dental students. I mean, the last 2 Thursdays I've had events talking with pre-dents and dental students. So no, I'm really
Well, and
excited.
I applaud you for that because I think I think you're totally private practice, aren't you?
Yes, right now until I've been waiting on hospital privileges. But yeah.
But what I mean by that is that you're not at an institution or you don't have any,
Right,
you're not spending more than say 25% of your time at a university.
right.
We need the private practice folks to mentor our dental students and pre-dental students about oral surgery because that's, the academic stuff, again, how many people go into academics of a graduating class a year? Maybe 5%, if anything. Do head
If
and neck. If you can do head and neck and cleft and craniofacial, yes, you have to go to an academic center. But majority of people are not doing those fellowships, right? The other 90% are going to private practice and they need to be mentored by people like you of the beauty of the specialty.
of all of
And
us,
yeah,
of all of
and
us.
they need to see all of it. The dental student needs to see that there's a variety of different pathways after you graduate, and these are what you can do. And everyone's happy doing those things, but these are the challenges.
Right. And now we have so many options on these pathways too. So let's get into that. So Buffalo, 4 years. Then you went to Case, 5 years. Then you did 1 year in Utah, or was it two? It was one.
1 year fellowship in Utah. Yep.
And what kind of drove you during residency at Case to go into the cosmetics direction? Did any other
Yeah,
people graduate and go that direction that you knew of?
yeah. So again, my chairman was again the person who actually created the 5 year track at Case, Dr. Goldberg, who then became the dean. When I was a junior resident, first, second year resident, he had a colleague who had done his dental school at Ohio State, oral surgery at Jacksonville, Florida, a dual degree, and somehow they connected over maybe some meeting. Well, his practice was solely cosmetic surgery because he was influenced by one of the founders or fathers of OMS in cosmetic surgery, Dr. Bob Alexander, which I believe he's passed. But he was a chair at Jacksonville, Florida. This oral surgeon, his name is Dr. Greg Smith, was colleague, friend of our chairman, and they created a deal that he would come up once a year, twice a year, for a weekend, essentially Thursday, Friday, Saturday, and we would get cosmetic cases together so we could do them with his supervision. And this way, Dr. Goldberg would expose us to cosmetic surgery, but also check the box, for CODA, for
Of course.
accreditation that the program got experience. And actually, in my third year, after him coming up a couple of times, he allowed me to come for a month, and I went down to his practice in Florida, Ponte Vedra, Florida. And if you're a big golfer, there's a TPC Ponte Vedra. That's one of the TPC players tournaments. It's got the island green, beautiful place. He lived there near that golf course, but his practice was in Ponte Vedra, and I spent a month seeing his cosmetic patients in his practice, and I said, you know what? I was torn between two fellowships, cleft and craniofacial, because I love orthognathic. I love these, taking care of these beautiful patients who are born with the unfortunate conditions of the craniofacial deformity. But I also love aesthetics, and he kind of geared me towards. I really got the aesthetics bug. So after spending a month with him in my third year, when I was in my fourth year, I looked around to see all the different fellowships that were available back then. This is 1998. And Dr. Kennedy's fellowship in Salt Lake City. Again, he was a Case grad from dental school. He knew my chairman because my chairman was a junior faculty when this doctor was in dental school. And he said, you know what, I know Dr. Brent Kennedy. Why don't you take a look at his cosmetics fellowship? And that's how it happens. It was sort of fortuitous. Before I left, then I made the deal that I was going to come back and expand our existing program to have full-time cosmetics at least. But I had to build it up. I had to build up that experience for the residents. It didn't happen overnight and took some time.
Of course. But do you have any residents rotate through your practice right now, or it's very separate?
Yeah, so up until July, they were rotating with me. But since I terminated my position with the university, I don't have any residents anymore.
Oh, okay. Oh,
But
okay.
that could change in the near future. But we'll see. Currently, no, we're just kind of making some dialogue.
Yeah. It might happen. Do you have
Yeah.
associates that you work with, partners in your practice? Is it just you?
Yeah, it's time to think about that. No, it's been all me for the last. So the practice opened up in 2003. So it's been, what, do the
Wow.
math, 23, it'll be 22 years, 23 years this coming March. And I've been, myself, my wife is my partner. She's an endodontist. So we have an endo oral surgery practice, and on the website you'll
Wow.
see that. So when I'm not there, actually, she's using our staff. We actually have worked in tandem for the last 22 years, where she'll see patients in the morning, I'll come in the afternoon to see patients, and our staff are cross-trained for oral surgery and endo, and it's been great. And we have a cosmetic nurse, aesthetics nurse in my practice, so she does now all the Botox and fillers, which I don't have to do anymore, which I've been doing for years. She does all my pre-opping and, patients with complex medical history. So
Yeah.
interfacing with the physicians in the area. We bring a CRNA for those complex cases into our surgery center. And we can do pretty much, any type of case that doesn't require overnight stay, from single jaw surgery to full arch surgery to facelifts and rhinoplasties and so forth. So we have a CRNA that governs our anesthesia for those longer cases. For the traditional oral
Yeah.
surgery, bread
Yeah.
and butter stuff,
You
I'm a
do it.
single provider model, which we will continue to have.
Oh yeah, God, that's man, that's another can of worms.
Another topic that we can discuss, because it's definitely, something that our association is always constantly fighting around the country, right? And because
Yeah,
of our competitors who want a piece of that economic pie of delivering anesthesia. That's really what it comes down to. There's
because
definitely a lot.
insurance doesn't. I mean, I just want to, but really, really briefly, it's because insurance isn't providing enough reimbursement for preventative care anymore. So then everyone inches its way up. So now you have general dentists doing more specialty work now. The specialists only getting the higher, most complex patients, those cases, and now we're getting the ASA fours, we're getting the Melonpotty fours, the obese people. That's who we're sedating in offices nowadays. I just wanted to butt in. I think insurance is the root cause of 90 something percent of these problems. But
Well,
anyway,
here,
anyway,
here,
thanks.
here, here we are as a specialty trying to do the best for the patient with risk now. And that's the problem. And I think what ends up happening is that, again, not going to the hospital, or maybe not having hospital privileges or what have you, we try to tackle on every type of case because
Yeah.
we're trying to help the patient out. And in doing so, we put ourselves in harm's way, essentially. And I think
Right.
we just have to be selective. We have to know how to screen and select our cases appropriately, and have that ability to take them somewhere or bring somebody in where you can offer the best care possible. I think every day we take a risk, right? Every day, the next time you sedate a patient tomorrow, if you're doing any cases tomorrow, you're taking a risk.
Right.
No matter how good you have done your screening method, whatever your method might be, how many years you've done it for, and it's reliable and it's great and safe, you're always taking a risk. Just don't, we can't help to forget about that, and sometimes we get lucky, right? Sometimes we get lucky.
I think every day there's a certain amount, there's a degree of luck every single day. But it's that luck it's getting tighter and tighter because like you said, it's a risk every day. That risk goes up over these years. The more complex patients and more complex cases that we're sedating. There's only so much. The roof hasn't moved. The roof hasn't moved only so much.
So
And
here's
with
a quite
yeah,
interesting thought. Think about everywhere else in the world. How is oral surgery in office delivered? With anesthesia or without anesthesia? If you've had any patients that have come over from Europe, or you've had people from the Middle East or patients from the Far East, I will tell you, oral surgeons over there do not give anesthesia in office. They're not trained.
oh,
So a lot of those people who have immigrated here and they work here now, they'll often say, I don't need to be asleep. I wasn't asleep for my other dental work or
yeah,
extractions. This society has been trained to be asleep. And that's the other issue, that
mm,
our society demands to be asleep, when we know that you don't need to be asleep for every oral surgical procedure. We have fear and anxiety and emotional and all sorts of other things that tie into that need of being asleep. Do we really need to be asleep for the majority of things that we do? Now, full arch, we're talking about something different. We're talking about,
yeah,
you know, single tooth extraction and socket preservation. Do you need to be asleep for that? Single dental implant. Do you need to be asleep for that? No, you don't. For a child, maybe someone who's Mizu dens or something like that. Yeah, you may, but then you have to think of where can we take these patients, or how can we deliver the care safely.
yeah, yeah. Oh, that's such a great point. In a way, our society has. Well, everyone's got complaints, right? Yeah, but everyone comes in the office. I mean, how many times a day you get someone coming? Oh, I need to be sedated for this. It's
A
one
lot.
tooth. It's one root. What do you mean? Everyone's coming in and want to be sedated.
But again, and the buck stops with you, and you meaning our specialty. We can say, no, this based on your history, based on your condition, even though you might be considered quote unquote stable, we're doing this awake for your own benefit. You have a 90-year-old, I want to be asleep. You really want to give a lot of Versed to that 90-year-old and, you know, exacerbate her already Alzheimer's? No, we don't. We don't need to. So I think we need to start appropriately selecting the patients that we want to provide that care for.
I hope we can. And now they have so many options out there where it's like, okay, I'll just go to the other office that'll do it. And then it's
Right.
like, oh no, wait, don't leave.
Right. How you
What
compete with yourselves, right?
do you think in our lifetime? Do you think? Because now here's another thing. I've made some TikTok content on the anesthesia thing, and there's always an anesthesiologist that wants to butt in and say, "Oh, it's so unsafe for the oral surgeon." I mean, look, oral surgeons have been doing this in the United States for what 50 plus years, putting patients to sleep and doing it. Now, look, there's always that risk. There's always that concern. But as far as safety goes, we're, I think, one of the most safe people to because we have that level where we keep someone so light, but they're just asleep. They're just there. Sometimes they can even respond to commands for people listening and viewing. Do you think there's a time in our lifetime where the anesthesiologists and some of the medical sides of healthcare and some of the other dentists, honestly, do you think they could take the dual provider and anesthesiologist come away from oral surgeons?
So this is going to be a sort of it's a multi-pronged answer. This is politically charged. We do provide a service to the community, and as long as we can provide that service, we will remain relevant. The problem is going to be the politicians in the deep pockets of these groups that are going against us because of um, the in Ohio we have now CRNAs wanting to have their own practice, independent practice, because they can only right now work under an MD.
Right.
They can't even work under a dentist, by the way, CRNA. CRNAs have to work under MD. They want their own independent practice. And when they do that, they're going to try to lobby for, well, we need to have business. Where can we get in? Well, if the hospitals don't want us, because the hospitals have now MD anesthesiologists on staff. They've got the AAs, the anesthesia assistants, which are cheaper to the hospital, function just as well as a CRNA. Well,
Yeah.
I can pay the cheaper, so I don't need the CRNA. Now the CRNA is going to look at our situation. I have to get into the oral surgery. You know what they're doing? They're going to the pediatric dentist and they're saying, don't send your patients to an oral surgeon. They need to be seen because they're kids. A bad outcome is going to happen with a child. You need to have, and they're lobbying now towards the pediatric dentists. And the pediatric dentists and the pediatricians are getting together, coalition against oral surgeons to do single provider model. So the answer to
Wow.
your question is, I mean, we are trying to fight, and we do have the statistics through OMSNIC, right, through our national insurance company, but we don't have the data to send to the dental boards where we are 100% safe. And the dental boards need to get that information because they'll keep our relevance of our general anesthesia, our permits, our ability to give anesthesia. It's under our Dental Practice Act. MDs, if you think about the history of medical doctors doing anesthesia, think about the GI specialist that did endoscopy. So scoping, colonoscopy, endoscopy, upper GI scopes, lower GI scopes. They were able to give anesthesia at one time. They no longer do. So they were also told by the medical board, no more. You're going to concentrate on just doing your scope. You're not going to do scope and give the anesthesia or sedation. Now, maybe what happens to us, I don't know. Maybe our level of anesthetic drops like you talked about. What you were mentioning, that person who's kind of in and out of sleep, is moderate sedation.
Right.
True
Right.
general anesthesia, as we know by definition, is no response to surgical stimulation, period, right?
Right.
So you give
Right.
them a local anesthetic, they don't even wince. They don't even move. But that requires a level of anesthetic, and depending on patient size, comorbidities, etc., you're going to give them how much drug to get to that level. So it's very complex. I wish the answer was quick for a little podcast. This is a discussion, and we
Big
are
can of worms.
being attacked by people who are looking to cut in again on our pie of services. But we do have a service and a need for community to help these patients because they can't go to the hospital to have a single tooth extraction. That's not going to happen.
Right.
Not at all. Now, we have our dental anesthesiologist. My daughter's a dentist anesthesiologist. She needs a job, right? So right now, she's providing a need to a lot of the pediatric patients, pediatric dentists in her community, because that's where her that's where her jurisdiction. She can't do anesthesia for belly surgery. So with her being a dentist anesthesiologist, she can only deliver anesthesia for head and neck and oral procedures. So she's joined a group that provides anesthesia care for special needs kids, and there's a need for that, as opposed to going to the hospital, where insurances are not going to reimburse the provider for the anesthesia provider in the hospital setting for that. So we've got it's a problem. And going back to your question, am I going to see a change in my lifetime? I hope not, because I hope we can at least, again, it's going to take some lobbying dollars, I believe, to help thwart those pressures from those entities that I mentioned earlier.
Yeah, yeah. It's scary. I can't tell you. I do, the mentoring and everything. I get asked this almost weekly, definitely monthly.
Yeah.
That's a little too often, to be asked that question. And that's a big part of our specialty. I think the data that we need to use data. I think we would say predictively, like how many less patients would actually receive care if they didn't have that access, our, ability to give them anesthesia. In dentistry, how can you? And I think that's going to be our defense. Yeah, we have to lobby. But we have to lobby with data. And how can you argue with numbers? Because everyone wants to bring numbers to the table. I think that's going to be.
So we have to. I think those numbers are important, as well as safety numbers as well.
Yes.
So
the safety.
the numbers of anesthetics, and again, you can go to insurance companies and you can see how many dollars are spent or how many numbers of procedures. Even in my own practice, I can tell you that in 23 years of my practice's existence, I've done over, 23,000 anesthetics. Yeah. And actually, they're inductions because I go to a general anesthetic. Now, induction by definition is when you give your medication, and they're now at a state where when you inject local or start taking a tooth, they don't even move. So we have huge numbers of success of delivering that anesthetic level of care safely in our specialty.
Yep. And we need to continue doing that. That's a really good point. The safety numbers, because that's another thing. How many of these general dentists are going to a weekend course and all of a sudden they can deliver conscious sedation or IV sedation even? I have friends that are doing this. I can't advocate. I can't support that,
Well, that becomes a dental board jurisdiction, right? So I actually served on the dental board as well, and I did it for 6 years. I served my governor, Kasich, and then now DeWine, and I came off of it a couple of years ago. But the dental board's role is to, obviously, for public safety care, and we just can't give the licenses for conscious sedation or general anesthesia willy-nilly. It's got to be you can't take a weekend course and get this conscious sedation permit if you're going to really talk about safety. There has to be a little bit more stringent guidelines of showing competency to get any level of anesthetic permit.
Right. I mean, you can read about a laryngospasm all day long. Until you see a laryngospasm, you're not going to know exactly what to do in the moment. Predicting it, you know it's coming on, right? To secrete whatever it may be, and how to manage that immediately, whether to prevent it or to break the seal. And I don't know, it's
because you
concerning.
And I know medication that a general dentist might say use for conscious sedation for one patient can be a general anesthesia for another patient.
Yes.
Based on age and all sorts of metabolic variables, right? And so them just saying, oh, I just give the same drug to every patient without a titration or without acknowledgement of coexisting condition, disease, they can actually go into a full general anesthetic. And now what do they do when someone's airway is lost?
Right. Patient comes in, all of a sudden they disclose to you they took a Xanax right before they walked in the office, and you were told they have no previous medical history, and now you have to try treat. Yeah, but you don't get that in a weekend course. Anyway, talk. We can really shoot the breeze here all night.
No,
we'll have to have a part two.
Definitely. I mean, this has been great. I love these podcasts. When I'm glad you didn't even send me any sort of topics to think about, because the best topics are the ones that come off the cuff and how the conversation sort of flows. And that's actually, compliment the way you run your podcast. So I appreciate that, and not having it scripted. So it's fun to have a conversation.
Right, it's a conversation, right? The scripts and stuff. That's not, and I know that you appreciate that now. So thank you for that.
Yeah, we'll call this the Larry David episode, a Curb Your Enthusiasm of Oral Maxillofacial Surgery, unscripted, not with humor, but with fact and reality, with reality.
Yeah, a little humor here and there, We'll have more in the next one, but so we're definitely gonna have to have a part two. I feel like we got a couple cans of worms. We got a couple bones to pick. This was great.
Absolutely.
So, Dr. Quereshy, thanks again so much.
And thank you for doing that. Thank you for doing something like this for the specialty for dentistry. I think I didn't go into your entire catalog of all the fun podcasts you've done, and that kind of took me. It was hey, listen, you got Ryan on there. Let's have a talk. We can.
Let's do it.
It won't be the same conversation as Ryan's. It'll be different, and that's what it's all about. We all
That's
bring
what
our
it's all
own
about.
unique experiences here, which is great.
And guess what? A couple months, we'll have a part two. It'll be a completely different conversation, right?
Love to do it. Love to do it.
We'll do it. We'll do it. All right. Well, I'll let you go. If you could just wait 10, when I hit the leave here, the end button, it takes about 10 seconds to upload. So otherwise, I got to send you an email with instructions. But all right.
No, I'll hold on. Great. Thanks, Brendan. Appreciate
Thanks
it, man.
again, Dr. Quereshy. We'll talk soon.
Be well. Take care.
You too.